Good afternoon, everyone. Thank you for inviting me to speak today. So I'm going to talk about screening and prevention of cervical cancer. It's a very rapidly evolving area. There have been a lot of interesting changes over the last 15 years that, and even particularly in the last 6 months, that I'm going to talk about. I have no relevant financial disclosures or other conflicts of interest. So my goals for today's talk are to talk about the role of primary HPV testing in cervical cancer screening, and to identify some gaps that are currently limiting us from using this in routine clinical practice, and then just some updates on HPV vaccination with the new 9-valent vaccine. So I'll start with where we've been and where we're at right now with cervical cancer screening guidelines. So as most of you probably know, current screening utilizes the Pap smear, which was developed by Dr. Papanicolaou in the 1920s, looking at vaginal cytology, and he really developed this field of exfoliative cytology, which is utilized not just with vaginal cells, but with all sorts of other washings, tissues as well. And it was really between the 1920s and 1940s that this area evolved, and he recognized that it could be used to identify cancer of the cervix. And then between the 40s and 50s, it became pretty widely adopted in developed countries as a screening tool. And as Dan alluded to, it's been a major public health success story. We've seen a reduction by 70% in cervical cancer mortality and a reduction by 75% in cervical cancer prevalence in those areas where it has been widely adopted. Guidelines for cervical cancer screening have evolved over the last 60 years. The elements that have evolved have been, as you're probably familiar, the age at which to initiate screening, the interval at which to perform screenings, the role that HPV testing plays in this, and then guidelines for when we can stop screening. And then kind of paralleled with that has been the evolution of the Bethesda guidelines, which guides how a Pap smear is interpreted and reported. So that's more for the pathologist side. So this is kind of a breakdown of the current screening guidelines. As OBGYNs, we tend to follow the kind of professional societies on the left, primarily the American Society for colposcopy and cervical pathology, although currently the two columns pretty much mirror each other. So we should be starting cervical cancer screening at the age of 21, regardless of prior sexual history. And then for 21 to 29-year-olds, they should be getting cytology once every 3 years, and only cytology. So there's no role currently for HPV testing in this population, and there is no role for annual Pap smears anymore. For slightly older women, so 30 to 65 years old, what is preferred is what we call co-testing. So that's simultaneous cytology and HPV testing every 5 years, assuming a negative test. Although cytology alone every 3 years, so Pap smear alone every 3 years is also acceptable. And it is recommended to avoid more frequent screening than every 3 or 5 years. Finally, sorry, I guess it's getting cut off, but when can we stop? So if a woman hits the age of 65 and she's never had CIN2 or worse disease in the last 20 years, and she's either had 3 negative Pap smears or 2 negative HPV tests in the last 10 years, we can stop screening. Or if a woman has had a total hysterectomy, meaning the cervix has been removed, and again has no prior history of CIN2 or worse. So even if she's 40 and she's had a total hysterectomy, for fibroids with no prior history of cervical dysplasia, we can stop screening in those patients. These guidelines are, of course, for the general population, so they would not apply to immunocompromised women, particularly HIV-infected women. And the screening guidelines do not change based on whether someone's had the HPV vaccine or not at this point. So where does HPV testing fall into this? HPV testing first was a part of cervical cancer screening guidelines as of 2002. And what the HPV test is a DNA test for high-risk HPV genotypes, so high-risk HPV types that are associated with causing cervical cancer. Depending on the HPV test, it may include 13 to 15 different strains of the HPV. And what's the rationale for adding HPV testing to general cervical cancer screening? Nearly 100% of cervical cancer is caused by persistent HPV infection, so it's essentially necessary to develop cervical cancer. And persistent high-risk HPV, particularly persistent HPV type 16, strongly predicts CIN3 or worse disease. The risk of developing CIN3 or worse is 20 to 30% over 5 years in someone who has persistent HPV type 16. HPV testing is also more sensitive than cytology, and we'll get into that a little bit more. And finally, it's an objective test that's more easily reproducible than cytology. The current clinical use of HPV testing is essentially, there's two roles that it can have. The first is in extending the screening interval for 30 to 65-year-old women. So that goes back to the guidelines that I had up earlier, where the preferred method is co-testing, with a negative co-test giving you a 5-year interval. The rationale for this is essentially that a positive HPV test increases your diagnostic lead time. So you would have prevalence of CIN3 would increase, but your incidence of CIN3 or worse should eventually decrease over time, because the HPV test is so closely linked to cervical cancer, and we tend to use CIN3 as kind of just before cervical cancer marker. So overall, if you have a negative HPV test, then your risk of developing cervical cancer is going to be lower. And so you have a longer interval time there that you gain by adding the HPV test to the Pap smear. In addition, as I mentioned, the risk with HPV is persistent infection, but 90% of HPV infections will clear on their own in a general healthy population, and that the average time to clear infections is 1 to 2 years. So that's where the 3-year marker starts from, and then we add time with the HPV testing. The other role that HPV testing has is in the triage of ASCUS Pap smears. So ASCUS Pap smears are atypical squamous cells of undetermined significance, essentially considered equivocal Pap smears. So there was a important study in the late 90s, the ALTS trial, which basically took about 3,500 women and put them either to immediate colposcopy after an ASCUS Pap smear, HPV testing, or just expectant management. And the study essentially found that the rate of detecting CIN3 or worse was the same in those that immediately went to colposcopy, and those that were triaged with the HPV test were only those that were positive went to colposcopy. So the detection rate was the same, but the number of colposcopies that were performed in the HPV triage group was halved. So it was a way to avoid unnecessary procedures, unnecessary colposcopies, while without increasing the risk of cervical cancer. So based on that study, we use high-risk HPV testing in the triaging of equivocal pap smears for women of all ages. And that's what this algorithm up here shows. So this is current clinical practice. So, we talked about what we are doing right now, but can we do better, and why do we need something better? So one issue is that cytology pap smears are actually pretty subjective. Within the ALTS trial that I was just discussing, the concordance between the clinical centers in the study and a quality control group of pathologists for pap smear interpretation ranged from 43 to 78%. And even within pap smears that were read as high grade, where you would think there maybe would not be as much variability, the concordance between the two groups of pathologists was only 47%. So this subjectivity then affects sensitivity of cytology. So in the Athena study, which I'll talk about more in detail, it was a recent study that looked at primary HPV testing. They found that across the 4 labs that they used, the sensitivity to detect CIN2 or worse ranged from 42 to 73% for cytology. So a lot of variation, but there's minimal variation when you look at HPV testing, since it's a DNA-based test. The other issues are that current guidelines that call for co-testing, so that means we're screening each woman with 2 tests. That means you have to deal with the results of 2 tests and the resources required to perform and interpret 2 tests. Finally, our hope, of course, is that with HPV vaccination, abnormal cytology will decline over time, so that would then affect the positive predictive value of cytology results. And then finally, abnormal cytology is going to tell you who already is affected by some degree of cervical dysplasia, whereas the HPV test is more a test of people who are at risk for developing dysplasia or down the road cancer. So this slide gets to the HC2 is the hybrid capture 2. It's basically high-risk HPV testing, and you can see what I was alluding to, that HPV testing is a more sensitive test. The concern is with the specificity, and that is why there was a set of cervical cancer screening guidelines issued in 2012, and in those guidelines they actually state that in most clinical settings, women aged 30 to 65 should not be screened with high-risk HPV testing alone as an alternative to co-testing at 5-year intervals or cytology alone at 3-year intervals. So they actually recommended against using HPV testing alone in those guidelines. And the reason was primarily to deal with the specificity issue there, because they felt it was going to lead to unnecessary colposcopy and additional procedures. The other factors that kind of affected that statement that they issued was that if we suddenly started doing high-risk HPV testing alone, so got rid of doing routine pap smears in women, how are we going to deal with the positives? What was the algorithm going to be for once a woman tested positive? We know that HPV is highly prevalent, especially in younger women, so now we're going to have all these positive women. What's the screening interval going to be for those that test negative? And how are we going to deal with testing errors related to specimen adequacy? Because there's a whole set of criteria when it comes to pap smears for whether a specimen is adequate or not. And then, since those guidelines were issued, there was a whole series of data, and there was an application to the FDA. The application to the FDA was from a current HPV test assay, which is used for co-testing, and their application was for approval to be used as in the role of primary cervical cancer screening. So that application to the FDA triggered an interim guidance panel to convene. It was a panel, and that's what I'm going to talk about next. So that panel was made up of the Society for Gynecologic Oncologists. It was made up of the ASCCP, and it was a total of 13 experts representing 7 different professional organizations. And their tasks were to primarily answer 2 questions. Was high-risk HPV testing for primary screening, so again, we would in some ways get rid of the pap smear, as safe and effective as using the pap smear alone? And second, could we then use it as an alternative to the current screening methods? In April, that application to the FDA was approved. So there is one high-risk HPV assay that is now approved to be used for primary cervical cancer screening in women 25 years and older. And just last month, that interim guidance panel that had convened published their guidelines. So I'm going to talk about what their guidelines discuss, essentially. So the first question was, how good is a negative HPV test? And they primarily focused this question on these 4 studies. And if you look, the HPV test basically performs better in terms of detecting or being safe in terms of cervical cancer and CIN3 or worse in each of the 4 studies. So the 2 that I'm going to talk about a little bit more are the RONCO study, which looked at pooled data from 4 previously published European randomized control trials that looked at conventional pap smear compared to HPV testing. And the valuable thing about this study is they followed women for a median of 6.5 years. In the first 2.5 years, there was actually not very much difference in the 2 arms. But when they followed them out longer, they found that the risk of of cervical cancer was essentially much lower in those tested by HPV testing. And their conclusion was that HPV-based screening provides 60 to 70% greater protection against invasive cervical cancer compared with cytology. So that's pretty impressive, what their conclusion was. The second study, which is a US-based study, the Athena study, found that the risk of CIN3 or worse for those that were co-test negative at enrollment was 0.3%. The risk of CIN3 or worse for those that were cytology negative at baseline was 0.8%. The risk of CIN3 or worse for those that were high-risk HPV negative was, again, 0.3%, essentially meaning that the risk, again, was much higher in the cytology-only group than the group that was tested with HPV testing alone. And I think what's even more impressive in some ways than those numbers is that among the women in this study that were diagnosed with CIN3 or worse, 47% had a normal pap smear at baseline. So this is a 3-year study. So at baseline, 47% of women had a negative pap smear that went on to develop CIN3, compared to 9.8% of women that had a negative HPV test, but then went on to develop CIN3. So again, kind of showing that HPV testing alone is pretty good. This is a little bit more of a population-based study. It looked at risk among over 300,000 women for CIN3 or worse over 5 years in a program out of Kaiser Permanente. So the cumulative incidence with a negative cytology-only screening was 36 over 10,000. With negative HPV-only testing, it was 17 over 10,000. And so that was a significant difference. The incremental benefit of co-testing, meaning what we're currently doing with our screening, is not significant. So co-testing doesn't really add very much to just doing the HPV testing. So in terms of the questions that the interim guidance was asked to answer, is HPV testing alone safe and effective compared to Pap smear? Yes, it looks like it's actually better than the Pap smear in terms of reassurance for having a low risk for CIN3. Their second question, can it be considered as an alternative? What the panel has said at this point is that because clearly high-risk HPV testing alone is very good, we can certainly use it clinically as an alternative, but at this point, it is still acceptable to either be doing co-testing or to be doing cytology alone. And this is the area where things are probably going to continue to evolve, I think, pretty quickly in the coming years. What role co-testing and cytology alone are going to continue to have. Then they spent a lot of time looking at this Athena study that I've mentioned a few times to answer some other questions related to what age to start screening and what interval to screen. And what the Athena study is a 3-year prospective study that was specifically designed to evaluate the role of primary screening with high-risk HPV test in women 25 years and older. What they found, so some of this we knew previously, the prevalence of HPV is much higher in younger women. So it was 21% in 25 to 29-year-olds, whereas it was about 12% in 30 to 39-year-olds. And then they confirmed that the 3-year cumulative incidence rate of CIN3 or worse was 25% among those that were known to be positive for HPV type 16 and 18, and it was much lower for those who were positive for the other 12 high-risk types. So there's an additional risk that type 16 and 18 have in terms of CIN3 and worse disease, and we know that 70% of cervical cancer is caused by type 16 and 18. The last thing that was pretty notable was the degree of CIN3 or worse that they found in young women. So 34% of CIN3 or worse was found in 25 to 29-year-olds, and 40% was found among 30 to 39-year-olds. And I had alluded to this earlier, that of the 25 to 29-year-olds that had CIN3 or worse, over 50% of them had a normal Pap smear. So one of the questions that the guidance was trying to answer was, how are we going to manage a high-risk HPV positive result? And this is the algorithm that they have recommended. This algorithm is essentially what the Athena study used. So the data supporting this algorithm is coming from one study, and the guidelines acknowledge that this algorithm could evolve with time as we have more data on what to do if we're going to incorporate HPV testing as the primary screening mechanism. And what this algorithm is suggesting is that we would do the HPV test. Those that test negative would just continue with routine screening once every 3 years or more. Those that test positive would then be further tested for type 16 and 18. And the rationale for that was because of the higher risk that type 16 and 18 pose for developing cervical cancer. And the ones that are positive for type 16 and 18 would go on for colposcopy. The ones that test positive for the other 12 types would then have a Pap smear. And if the Pap smear is negative, they would go to colposcopy. But if the Pap smear is negative, then they would be tested again in 12 months. So as I mentioned, that the panel also answered some secondary questions. These secondary questions have more limited data. The first was, what's the optimal interval for primary high-risk HPV screening? They concluded that women should not be rescreened more often than every 3 years if we're going to use HPV testing only. This recommendation is based on essentially the data from the Athena study, which only followed women for 3 years. And so during those 3 years, the cumulative incidence of CIN3 was less than 1%. It's also supported by data from out of Kaiser Permanente. There was another larger study that looked at 1 million women, and they essentially concluded from that study that the 3-year risk of CIN3 or worse was, for HPV testing alone, was less than the 5-year risk of co-testing, so less than our current guidelines. And so they felt that those two sets of studies supported screening at 3 years, that there's not enough US-based data right now to support a longer screening interval. There is some data out there that the pooled set of 4 European studies that supports 5 years, but because it wasn't US-based data, the furthest that the panel was willing to recommend was a 3-year interval. And then, what age should one initiate primary high-risk HPV screening? So this is probably the area that is going to generate the most controversy, because on one hand, we saw that there was, from the Athena study, that there was actually a pretty substantial amount of 25 to 29-year-olds that developed CIN3, but the downside to starting screening this young is the number of women who are going to end up getting colposcopy. So compared to pap smears alone, the number of women having to go for colposcopy doubled in this study. So where the scales kind of balance out in this, I think, is going to evolve. But for now, this interim panel has said we can initiate as early as age 25. So what are the gaps? I've kind of alluded to some of these gaps already. HPV is highly prevalent in the population, especially among young women. So we really need to think about how we're going to manage all these positive women. I showed you one algorithm that is what's being supported right now by the interim panel, but there are a lot of studies ongoing right now looking at different strategies, and so the guidance may change as to exactly what we're going to do. The other issue is this age issue. So the balance between the number of unnecessary procedures, particularly colposcopies, versus detecting a higher degree of CIN3. Part of this is that we may detect the CIN3 earlier, but we don't know if that's actually going to contribute to a meaningful reduction in cervical cancer. The natural history for cervical cancer is very long. And so is the added 4 years going to make a difference, as opposed to waiting till a woman is 30 and initiating the HPV testing at 30, which is what we do currently. And then the other issue is there are a set of guidelines for managing abnormal cervical cancer screening for 21 to 24-year-olds. So how are we going to transition women from that set of guidelines into a recommended HPV testing for 25-year-olds if we also are not supposed to be testing more often than every 3 years? So there's a lot of kind of different guidances that need to be reconciled here. The issue of specimen adequacy, as I mentioned before, with pap smears, there are criteria for how we determine that a sample is adequate. Those same types of criteria don't exist for HPV testing. And then there's more of a logistical issue where there are 4 HPV assays out there, but only one of those 4 is currently FDA approved to be used as a primary screening method. And so any provider that wants to start using primary HPV testing needs to figure out what's being used in their lab, since we should, adhere to the FDA approved guidelines. And then finally, right now, we're seeing, based on the guidance, screening not more often than every 3 years. but there may be a role in the near future for extending that out further as we get more data. I'll just go really quickly through the 9-valent vaccine. So as you may or may not know, the 9-valent HPV vaccine was recently FDA approved. So it includes the 4 HPV types that are in the current Gardasil vaccine, and it adds 5 additional high-risk types. So it has the potential to prevent 90% of HPV-related cancers. And then the CDC just recently voted and approved recommendation of this vaccine. And so their recommendation for what ages is unchanged from the prior Gardasil vaccine. It's recommended to for 11 to 12-year-olds as a target age. It can be initiated as early as the age of 9, and it's recommended for 9 to 26-year-olds among females and 9 to 21-year-olds among males. And the important thing that they've said is that if someone comes in needing the HPV vaccine, you can give them any of the types of HPV vaccine out there. It doesn't matter what they were previously vaccinated with for the first dose or the second dose. You can, for their next dose, you can give them whatever you have. And so the nice things about this HPV-9 vaccine are that we're getting a 20% additional coverage in terms of protection for cervical cancer. Also, globally, while I've said that types 16 and 18 account for 70% of cervical cancer, globally there's a little bit more variability as to how much of cervical cancer is accounted for by 16 and 18. That variability is made up for by the other 5 types that have been added to HPV-9. So it puts all the different regions of the world at kind of a more even playing field in terms of the potential for preventing cervical cancer by adding these 5 additional types. And relative to the current vaccines, 9-valent is estimated to prevent another 100,000 cases of cervical cancer a year. There was a recently published efficacy trial, which basically tells us that the 9-valent is as good as the 4-valent vaccine, with the adverse reactions primarily being injection site. And then the last thing I wanted to touch on was that there's a lot of science and it's really exciting, but it doesn't really come out too much because we're not implementing it. Both on the screening end and on the prevention end. So the most recent data from 2013, our coverage rate among girls and boys is low, both in terms of getting at least 1 dose or in terms of completing the vaccine. And so it's an area that we really need to work on. This is obviously national data, and then we've looked at it here in the Women's Center, where we see a large low-income minority population, and our, getting women 1 dose is 24%, completing their series is only 13%, and 56% of women who need to get an HPV vaccine dose had a missed opportunity where they had a health encounter and we failed to vaccinate them. So we are currently working in the Women's Center on evaluating a series of low-cost interventions to improve vaccination rates among our New Haven population. Thomas Ray is a well-known pathologist that spent a lot of time working in this area. Recently made the point, as I was saying earlier, that we have a highly effective vaccine, we have highly effective screening strategies. What we really need to do is to integrate all of this in kind of the most optimal way possible, because right now more than half of cervical cancers are diagnosed in women that were never screened, and another 10% are diagnosed in women that are under-screened. So in parallel to the vaccination story, the science is really exciting, like I said, but we need to work on the other end of really implementing and getting it out to the population. I'm happy to take questions. Thank you.